Welcome back to the deep dive. Okay, so imagine you've got this stack of quick notes, right? The kind you'd scribble down or grab, full of just the essential facts for a critical care situation.
Yeah, like cheat sheets for saving lives.
Exactly. And that stack of notes, well, that's our map for today. We're going deep into some really core critical care stuff. Handling emergencies, figuring out hormone issues, supporting breathing, and, the basics of the ICU. Our mission, basically, is to pull out the absolute must-know info from these notes. Maybe give you a shortcut, help you get a handle on it, especially if you're, say, just starting out or need a quick brush up.
Right. And these notes, they're great for the what are the signs, what's the treatment, but we want to dig into the why a bit too.
Yeah, understanding why makes it stick, doesn't it?
It really does. It turns facts into actual understanding. These aren't just theories. This is practical stuff you'd use.
For sure. Recognizing subtle changes, knowing the immediate next step, it's high-stakes knowledge.
Absolutely. These quick facts are the foundation. Let's help you build on that.
Okay, let's dive in. Let's unpack this stack of notes together. All right, first up, the notes jump right into the absolute core, spotting immediate danger, knowing who needs help right now.
Yeah, the triage, the prioritization, it starts there.
And they kick up with a really serious one, opioid overdose. A true life threat.
A scenario where seconds count, definitely.
Yep. So the notes give us this classic thing to remember, the opioid overdose triad. Super helpful. It's 3 key signs you look for. First one, meiosis.
Pinpoint pupils, right. Very constricted.
Exactly. Second, respiratory depression. So breathing is slow, shallow, maybe almost stopped.
That's the really dangerous part.
And third, a decreased level of consciousness, like they're hard to wake up or totally unresponsive.
And seeing those 3 together, meiosis, slow breathing, decreased LOC. That's a huge, huge red flag for opioids.
And the notes are clear on the immediate fix, naloxone. You probably know it as Narcan.
Yeah, it's the reversal agent, an opioid antagonist. It basically knocks the opioid off the brain receptors.
And that reverses the effects, especially the breathing problems.
Super fast,
yeah.
Usually. Knowing that triad and knowing Narcan, that's baseline emergency knowledge for sure.
Okay, building on that idea of immediate threats, the notes tackle prioritization, the classic question. You've got multiple people in trouble. Who do you see first?
Right, and this isn't just for nurses or doctors. It's for any first responder, really. You have limited time, limited attention. Where do you focus first?
And the notes give a really concise answer. You go for the patient who is the most unstable, the most acute, the one with the unexpected problem. The one with an ABC issue, airway, breathing, circulation problem, and the one who needs help right now.
That framework is absolutely critical. It stops you from getting, overwhelmed. You scan for the immediate life threats. Is their airway clear? Are they breathing okay? Do they have a pulse, good circulation?
So how do you quickly figure out who fits that description? That unstable, acute, ABC, now patient?
Well, it's about looking for the obvious signs of distress, right? But also comparing them to how they were maybe a minute or 5 minutes ago, any sudden change. And zeroing in on those ABCs. What's their pulse? How hard are they working to breathe? What's their skin color look like? Are they responding to you? Those are your quick clues to instability.
Got it. Okay, let's shift from those immediate, first response things to a couple of really complex medical emergencies that often land people in critical care. The notes compare DKA and HHS.
Diabetic ketoacidosis and hyperosmolar hyperglycemic state.
Yeah.
Both related to diabetes, both very serious high blood sugar problems, but quite different in how they develop and how you treat them.
The notes lay out the key differences really well. DKA, that's mostly seen in type 1 diabetes, right?
Typically, yeah.
And the big things are ketones are present. You'll find them in the blood and urine. And the blood pH is low, like less than 7.3. They're acidotic.
Exactly. Acidosis is key in DKA. HHS, on the other hand, usually affects type 2 diabetics. And crucially, ketones are generally not a major feature. Minimal, if any.
But their blood sugar.
Oh, it's often way higher than in DKA. The notes say over 600, but it can be, over 1,000 sometimes. And the other big thing is very high serum osmolality.
So DKA is that trio, high sugar, ketones, and acid. Why the ketones and acid in DKA?
Well, in type 1, there's basically no insulin.
Sure.
So the body can't use glucose for fuel. It starts desperately breaking down fat instead.
Okay.
And the byproduct of breaking down all that fat is ketones, which are acidic. They build up and boom, you get acidosis.
Right. But in HHS with type 2, they still make some insulin.
Usually, yes. Enough to prevent that massive fat breakdown in ketone production. So no significant acidosis. Their main problem is profound dehydration.
How does that happen?
The kidneys are trying to filter out all that excess sugar, and sugar pulls water with it. So they just pee out mass amounts of fluid, leading to extreme dehydration.
Okay, so treatment for HHS, according to the notes.
Priority 1 is fluids. Lots and lots of IV fluids to rehydrate them. Then insulin, usually an IV drip, to bring the sugar down. And you have to watch electrolytes really closely, especially potassium.
Why potassium?
Insulin drives potassium into the cells along with glucose, so giving insulin can make their potassium level drop, sometimes dangerously low. Plus, you got to find and treat whatever triggered it, often an infection.
You mentioned that high serum osmolality in HHS. The notes define it, right?
Yeah, they say it's a concentration of solutes, like salt and sugar, in the blood. It basically tells you how concentrated or dilute the blood is, which reflects hydration status.
So it's like how salty the soup is. If there's less water and more stuff dissolved, it's more concentrated, higher osmolality.
That's a pretty good analogy, yeah. In HHS, the blood is thick with sugar, and they've lost so much water, so the osmolality goes way up. That concentration also pulls water out of brain cells, which is why they often have neurological symptoms, like confusion or coma.
Okay. And for DKA, the notes list similar priorities, but with some differences.
Right. Fluids are still crucial, often normal saline first. And insulin drip is key to stop the ketone production as well as lower the sugar. And again, watching potassium is vital. But here, you also have to actively manage the acidosis.
Makes sense. The notes also list common triggers for DKA, things like infections.
Infections are a big one. Also, missed insulin doses or any kind of major stress on the body, illness, surgery, trauma.
Which actually leads perfectly into something else that the notes cover. Sick day rules for people with diabetes. What should they do when they get sick, like with the flu?
This is really important practical advice.
Yeah, and some of it feels a bit counterintuitive. Like the notes say, check your blood sugar more often, maybe every 4 hours. Stay hydrated, obviously. Check for ketones. But then it says continue taking your insulin.
Wait, even if you're sick and maybe not eating much, wouldn't that risk going low?
That's what I thought, but the notes are clear. Keep taking it. And call your doctor if you're vomiting or if your sugar stays high, like over 250.
So why keep taking insulin if you're not eating?
It goes back to those triggers. Being sick puts stress on your body, releases stress hormones.
Which can actually make your blood sugar go up even without eating.
Exactly. So skipping insulin when you're sick because you're not eating is actually a common way people end up in DKA. Those sick day rules are vital self-management.
Absolutely critical. Okay, shifting gears a little, but still in the endocrine world. The notes bring up potential problems after thyroid surgery, a thyroidectomy.
Right. They mention two main things. Hypocalcemia, low calcium, which can cause numbness or even muscle spasms, tetany, and hoarseness.
The hoarseness is usually from potential injury to the recurrent laryngeal nerve, which runs near the thyroid and controls the vocal cords. But why the low calcium?
Yeah, what's the connection between the thyroid and calcium?
It's anatomy. Right behind the thyroid gland are these tiny little glands, usually 4 of them, called the parathyroid glands.
Okay.
They control calcium levels by making parathyroid hormone, PTH. During thyroid surgery, because they're so close and small, they can sometimes be accidentally injured or even removed.
Ah, so if the parathyroids are damaged, you don't make enough PTH, and calcium levels drop.
Precisely. That's why hypocalcemia is a known risk.
And the notes list those classic signs to watch for, Schwastek's and Trousseau's signs.
Yeah, those are physical exam maneuvers. Schwastek's is tapping on the facial nerve.
And the face twitches, right?
Yep. And Trousseau's is inflating a blood pressure cuff on the arm.
And the hand cramps up in a weird way, like a claw.
That's the one. Carpopedal spasm. Both show that the nerves are hyperexcitable because of the low calcium. The notes also mention tingling, especially around the mouth or fingertips, and muscle spasms or cramping.
Good signs to know. The notes then rattle off a few other endocrine points pretty quickly. Cushing's syndrome.
Which is too much cortisol. The notes link it to high blood sugar, higher infection risk, high blood pressure, and low potassium.
And successful treatment should show the opposite. Lower blood sugar, maybe some weight loss, potassium coming up, but they warn about overtreatment leading to adrenal insufficiency.
Right, the opposite problem. Which brings us to Addison's disease. Not enough cortisol.
And the expected findings listed are pretty much the mirror image of Cushing's. Low blood sugar, low blood pressure, signs of dehydration, high potassium, low sodium, and fatigue.
It makes sense, right? Opposite hormone problem, opposite findings. And the notes highlight triggers for an Addisonian crisis, a life-threatening flare-up. Stress, infection, or abruptly stopping steroid pills are common culprits. The body just can't cope without that cortisol boost.
Okay, then hyperthyroidism, overactive thyroid. The notes mention PTU, propylthiouracil, as a medication, and they define thyrotoxicosis
As a really severe state of hyperthyroidism, often called thyroid storm, an emergency.
And for the opposite, hypothyroidism, treated with levothyroxine, the notes give key teaching points.
Yeah. Take it in the morning, empty stomach for best absorption. And this is crucial. It's lifelong therapy.
That lifelong part is important. You don't just stop when you feel better.
Nope, the thyroid isn't fixing itself. The notes also mention myxedema coma.
Which is described as severe hypothyroidism. You'd expect everything to be slowed down, low vital signs, slow metabolism, and treatment needs to be slow and careful.
Yeah, rapid correction can actually be harmful. Then there's radioactive iodine therapy, sometimes used for hyperthyroidism. Notes list side effects.
Dry mouth, metallic taste, and eventually it often causes hypothyroidism because it destroys thyroid tissue.
Makes sense. And the teaching for patients getting it.
Pretty specific stuff to protect others from radiation. Drink a lot, pee a lot to flush it out, and avoid close contact for a bit.
Good practical advice. Lastly, in this endocrine whirlwind, the notes touch on SIADH and DI.
Syndrome of inappropriate antidiuretic hormone and diabetes insipidus, both related to ADH, the water balance hormone.
Right. ADH tells your kidneys to hold on to water. SIADH, the notes say, is too much ADH.
So you hold on to too much water.
Exactly. Which dilutes your blood, leading to low-sodium hyponatremia. Symptoms listed are that low sodium, low urine output, even though you're overloaded with fluid, confusion from the low sodium, and weight gain from the water retention.
So treatment is basically the opposite. Restrict fluids.
Fluid restriction is key. Sometimes meds like dimethylcycline, and in severe cases, very carefully giving concentrated saline, like 3% saline, to bring the sodium up.
Okay, then DI, diabetes insipidus, is the flip side.
Totally the opposite. Instead of too much ADH effect, there's not enough. Either the brain doesn't make it or the kidneys don't respond to it.
So the kidneys don't get the signal to hold on to water.
Right. So they dump massive amounts of dilute urine. Patients become very dehydrated. Fluid status is dehydrated, according to the notes.
And the main treatment listed is desmopressin, DAVP.
Which is synthetic ADH, basically replacing what's missing or not working.
Monitoring for these patients sounds intense. Strict INO, daily weights, checking serum sodium, urine-specific gravity.
You have to track their fluid balance and sodium very closely. The key labs listed are sodium, osmolality, BUN, and hematocrit, all indicators of hydration status. It's amazing how these two conditions, SIADH and DI, are such perfect opposites, all down to one hormone.
Wow, okay, that was a serious dive into hormones. Let's catch our breath and switch to the lungs. Respiratory support, airway stuff, absolutely critical.
Foundational. Can't live without oxygen getting in and CO2 getting out.
The notes really stress arterial blood gases, ABGs, as a key tool, and they give a nice, clear order for interpreting them.
Yeah, a systematic approach is best.
Step 1, look at the pH. Is it acid or alkaline? Step 2, check the COUS, that's your respiratory indicator. Step 3, check the HCO, the bicarbonate, that's metabolic.
Right. Then you match. Does the K-Euros or the HCO abnormality explain the pH change? That tells you if it's primarily respiratory or metabolic.
And finally, you look at the other value to see if the body's trying to compensate. It gives you a roadmap to the acid-base situation.
Exactly. Helps you understand what's going wrong physiologically.
The notes also have this really practical positioning tip. Say a patient has one lung that's pretty bad, maybe filled with pneumonia, and the other lung is relatively okay. How should you position them? Bad lung up or down?
So say, keep the bad lung up.
Okay, see, that feels wrong to me. I think you want to rest the bad lung, put it down.
I know, it seems counterintuitive.
Yep.
But think about gravity and blood flow. Where does blood naturally go in the lungs?
Yeah, the bottom parts.
Right. So if you put the good lung down, gravity pulls more blood flow to that healthy, well-ventilated lung tissue.
Ah.
And by keeping the bad, poorly ventilated lung up, you're naturally diverting blood away from the area that can't oxygenate it well. It's called improving VQ matching, ventilation perfusion matching. Good lung down is the way to go for better oxygenation.
Okay, that makes total sense when you explain the blood flow part.
Cool.
The notes also cover care after intubation, putting in a breathing tube. What's the absolute first priority?
Confirmation of placement. The notes are clear. You have to make sure the tube is in the trachea, the windpipe, and not down the esophagus into the stomach.
How do you confirm them?
Several ways listed. Checking for end-tidal CO2. ET CO2, you should get CO2 back if you're in the lungs. Listening for breath, sounds equally on both sides of the chest, and not hearing gurgling over the stomach, and getting a chest x-ray.
And once it's confirmed,
Secure the tube really well so it doesn't move, and monitor vital signs closely. Getting that placement right is job number one.
absolutely. And once they're on the ventilator, preventing VAP, ventilator-associated pneumonia, is a huge deal. What do the notes say?
Key things: good oral care, keeping the head of the bed elevated, doing daily checks to see if they can come off sedation, called sedation vacations, and suctioning secretions as needed. These are all part of standard VAP prevention bundles.
Makes sense. The notes also help decode ventilator alarms, high-pressure alarms.
Usually mean there's some kind of obstruction. Could be secretions that need suctioning. The patient might be coughing or biting the tube, or maybe there's a kink in the tubing. Something's blocking the air from going in easily.
And low-pressure alarms.
That usually means a leak or a disconnection somewhere. The air isn't meeting the expected resistance. Maybe the tubing popped off the ventilator, or the patient's endotracheal tube cuff has a leak. Different alarms point to different problems.
Got it. The notes also quickly define a bag valve mask, or ambu bag.
That's that manual resuscitator, yeah.
Yeah.
What you use to breathe for someone if they aren't breathing or if the ventilator isn't working right.
Okay, moving to chest trauma. How do you prevent hypoventilation, shallow breathing after someone hurts their chest? Because breathing must hurt like crazy.
It really does. So the notes emphasize pain control. That's number one. If it doesn't hurt as much, they can breathe deeper. Also using an incentive spirometer to encourage those deep breaths and positioning them comfortably.
Pain control seems key there. What about finding crepitus after a chest injury? The notes say that means subcutaneous emphysema, and you should tell the doctor. What is crepitus? What's it feel like?
Subcutaneous emphysema is when air leaks out of the lung or airway and gets trapped in the fatty tissue under the skin. When you press gently on that area, it feels... Well, the classic description is like Rice Krispies popping into your fingers.
Oh, wow. Okay, that's a feeling you'd remember.
Definitely. It tells you there's an air leak somewhere.
The notes also mention flail chest. What kind of chest movement do you see?
Paradoxical movement. It's when a section of the rib cage is broken in multiple places and becomes unstable, detached from the rest of the chest wall.
So it moves. Weirdly.
Yeah, opposite to normal. When the person inhales and the rest of the chest expands out, that unstable flail segment gets sucked in. When they exhale and the chest moves in, the flail segment bulges out. It's a sign of severe chest trauma.
Yikes. Okay, chest tubes. Used to drain air or fluid. What are the key care points from the notes?
Keep the system below the level of the chest. That's crucial for gravity drainage. Make sure there are no dependent loops or kinks in the tubing. Maintain an occlusive, airtight dressing at the insertion site, and monitor the system for air leaks, which usually show up as bubbling in the water seal chamber.
That below the chest rule seems fundamental. And after the tube comes out,
apply another occlusive dressing immediately, and watch closely for any signs the pneumothorax or effusion might be returning. Definitely need to watch them. And speaking of pneumothorax, the notes highlight a really dangerous type, tension pneumothorax.
Right. This is where air gets in the chest space but can't get out. Pressure builds up.
And it builds fast. It collapses the lung on that side, sure. But the real immediate danger is that the pressure pushes the heart and the great vessels over to the other side, called a mediastinal shift.
Which messes with the heart's ability to fill and pump.
Exactly. It causes cardiac output to plummet. It's a double whammy: severe respiratory distress and cardiovascular collapse. A true emergency.
And the immediate treatment listed.
Needle decompression. Sticking a large bore needle into the chest to let that trapped air escape instantly and relieve the pressure. Buys time for a chest tube.
Speed is critical there. Okay, few more quick pulmonary points. Signs of pulmonary edema, fluid in the lungs.
The notes list crackles heard on auscultation, that classic pink, frothy sputum.
That's a very vivid image.
It is. Also shortness of breath, hypoxia. And then pulmonary embolism, PE, a blood clot in the lungs. How to avoid it.
Teaching points focus on prevention, staying hydrated, moving around, using those leg squeezer things, SCDs, and sometimes blood thinners, anticoagulation.
All about preventing clots from forming in the legs, DVTs, and traveling to the lungs. What's the best test to diagnose a PE, according to the notes?
CT, pulmonary angiogram.
It's a gold standard, usually. And symptoms.
Sudden shortness of breath is a big one. Chest pain, especially pain that gets worse when you breathe in pleuritic pain. And a fast heart rate, tachycardia.
That sudden onset is really characteristic. Okay, almost done with respiratory. ARDS, acute respiratory distress syndrome. What are the signs?
The big one is refractory hypoxemia, meaning their oxygen level is dangerously low, and it doesn't get better even when you give them lots of oxygen.
That's the hallmark. The lungs are just so injured and inflamed, oxygen can't cross over into the blood effectively. Other signs listed are fast breathing, tachypnea, and seeing diffuse white patches, infiltrates, all over the lungs on the chest x-ray.
And how do you know if someone with ARDS is getting better?
Signs of improvement listed include their PA2, arterial oxygen level, starts to rise. They need less supplemental oxygen, a lower FiO2, and their lung compliance improves, meaning the lungs become less stiff, easier to ventilate.
Good benchmarks. And just generally signs of hypoxia, low oxygen.
The notes mention restlessness, maybe confusion. Those can be early signs, especially in adults.
Before they turn blue?
Often, yes. Also cyanosis, the bluish color, increased heart rate, increased respiratory rate. The body's trying to compensate.
Okay, one last respiratory point from the notes. Contraindications to prone positioning. Turning the patient face down, which sometimes helps in severe ARDS. When shouldn't you do it?
Notes list things like unstable spinal fractures, certain types of chest trauma, or an unstable pelvis. Basically, situations where the prone position itself could cause further injury.
Makes sense. Okay, we've hit emergencies, endocrine, respiratory. Let's move to the last section in these notes, some broader ICU principles and care topics.
Right. Things about managing the patient and the environment.
Sedation comes up. The notes mention dexmedetomidine, Precedex. What's special about it?
Its key feature, highlighted in the notes, is that it provides sedation, but often without suppressing the patient's respiratory drive as much as other sedatives might.
So they can be sedated but still breathing on their own?
Potentially, yes. Which can be a big plus. The notes also give a time frame for propofol.
Says it wears off quickly, about 5-10 minutes.
Which is why it's useful when you need to wake the patient up frequently for neurochecks, for example. Very controllable.
And the reversal agent for midazolam or
Flumazanil. Good to know if you need to reverse a benzodiazepine quickly. The notes also mention the RAS score.
RSS Richmond Agitation Sedation Scale. What's that measure?
It's a standard way to assess and communicate how deeply sedated or how agitated a patient is. The scale goes from +4, which is combative,
Okay.
down through 0, which is alert and calm, to an income 5, which is unarousable, no response to voice or physical stimulation.
So it gives the team a common language for the patient's sedation level.
Exactly. Helps guide station management. And speaking of the ICU environment, the notes list risk factors for ICU delirium.
Yeah, things like sleep deprivation, being on sedatives, having physical restraints, and not being able to move around much, immobility.
These are huge. Delirium is incredibly common in the ICU and can lead to longer hospital stays and even long-term cognitive problems. So minimizing these risk factors, trying to promote sleep, using less sedation, mobilizing patients early, avoiding restraints if possible, is really important preventative care.
Absolutely. And the last point in the notes touches on ethics. When might you need to get the ethics committee involved?
The notes suggest involving them in situations like really complex decisions where the best path forward isn't medically clear-cut, when there's significant disagreement between the medical team and the patient or family about the plan of care or navigating difficult end-of-life decisions.
So they help when things get complicated ethically.
Yeah, they provide a forum for discussion, help clarify values, and offer guidance. They don't usually make the decision for people, but they facilitate finding a resolution that respects the patient's wishes and values. It brings up that tough question, how do you balance what's medically possible with what's truly right for the individual, especially when people disagree?
That's a heavy but important aspect of critical care. Wow, we have really unpacked this stack of notes today. Covered a lot from those first few minutes of an emergency through complex DKA-HHS, thyroid issues, ADH problems, all the way to ventilators, chest tubes, ARDS, and even sedation and ethics.
It's a lot. But these quick facts, as we said, they're the essential building blocks. Hopefully going through them like this, adding some of the why, has made them click a bit more, whether you're learning this for the first time or just refreshing your memory.
Yeah. It's amazing how all these separate little facts, a lab value here, a physical sign there, knowing about a specific medication or how to position someone, they all have to come together instantly in the care of someone who's critically ill.
It really highlights the complexity. Think about everything we just touched on, the opioid triad. DKA versus HHS differences, good lung down positioning, VAP prevention, ventilator alarms, RAS scores, when to call ethics. Makes you wonder, doesn't it? How does the sheer speed and sometimes the fragmented nature of critical care information challenge everyone involved, nurses, doctors, respiratory therapists, to pull all that knowledge together accurately right now under immense pressure. What part of integrating all that diverse critical information seems like the biggest challenge to you?
Something definitely worth thinking about. Keep exploring, keep learning.
And we'll see you on the next Deep Dive.